by electrolytes. So now we have our next chapter, chapter 12, acid-base balance. So on page 187 of your books, it talks about the difference between acid and bases. So we're looking at the most common base in the body is bicarb, right? Um, which is what we're looking at. And we are trying to maintain a balance between carbonic acid and bicarbonate. That's what we're looking for. The constant ratio is related to balancing the production and elimination of carbon dioxide and hydrogen ions, which is the H plus there, all right? I want you to look at just look at where it says carbon dioxide is a gas. It forms carbonic acid when combined with water, and that's what makes carbon dioxide. And we keep a ratio of 1 to 20 with the carbonic acid to bicarb. So the reason I want you to be aware of that, and I don't really want to get into too much detail, but this is where we look at, and you may see it in some electrolyte panels, where they talk about the ion gap. And that's what they're sort of talking about with that ion gap. The ratios are off. So I just wanted to bring that into your awareness. And it's not something we're really going to deal too much about, but that's what I wanted you to be aware of when you may hear somebody talking about the ion gap. All right, there's a difference there. It's also related as well to other electrolytes in the panel, but this could be part of it. Okay, so what are we looking at? Carbon dioxide is a gas. It's eliminated during exhalation, right? And that's one of the most important actions for this acid-base balance. And that's what we're really trying to do. We're trying to maintain a balance in the body. The extra CO2 is eliminated during exhalation, helping to bring the hydrogen ion concentration down to normal. Whenever the CO2 level changes, the pH changes to the same degree in the opposite direction. And that's where that Rome piece comes in, right? Thus, when the CO2 level of a liquid increases, the pH drops, again, the opposite direction. Likewise, when the CO2 level of a liquid decreases, the pH rises. So indicating fewer hydrogen ions, and therefore it's more alkaline. So one is more acidic and one is more alkaline. And I think you guys are somewhat familiar with all of that. An increase in bicarb causes the amount of hydrogen to decrease and the pH to increase, and so it becomes more alkaline. And likewise, a decrease in bicarb causes the hydrogen levels to increase and the pH to decrease, and so it becomes. So I just want you to be aware that the lungs are the ones that control CO2 and the kidneys control bicarb. All right, so just be aware of those pieces. And at the on page 188, it gives you chart 12.1, and it just shows you the pH, the PaO2, 80 to 100, the PCO2, 35 to 45, the bicarb, those range a little bit. It says here 21 to 28. Sometimes those ranges are slightly different, but it will be in that range. All right, so just be aware of those things. All right, so on page 188, two things I want you to be aware of. Down the bottom here, it says incomplete breakdown of glucose. This occurs whenever cells metabolize under an anaerobic. And anaerobic means no oxygen conditions, and it forms lactic acid. Can any of you think of a situation where lactic acid occurs, just out of curiosity? Any of you?
Is it when I don't know if it's, am I thinking the right thing when I say like if a runner goes and trains
Yeah.
in the mountains or something, and I don't know.
Yeah. So, and not just in the mountains, people that work out a lot, if they're not careful, you can actually see this buildup of lactic acid occur in their muscles, and that's what causes that pain. You know, and they're like, oh, I've got a cramp or I've got muscle pain. It's that lactic acid buildup. Absolutely. That's what's going on there. There isn't enough oxygen, right? There's not enough oxygen to the cells, there's not enough oxygen to the muscles, and they've got this lactic acid buildup. And other conditions, of course, can cause that as well: hypoxia, sepsis, shock. Another thing that, and this is why I'm not really crazy about one of those diets, the keto diet. I'm not really a big fan of that. What are you getting? You're building up your ketones, right? So I'm not a big fan of, I'm not really a big fan of any diets per se. I know that there's some health benefits to the keto diets and also to fasting type of diets, but you are building up your ketones, and I'm not really sure that that's a great thing to do, because like it talks about here, incomplete breakdown of fatty acids occur when large amounts of fatty acids are being metabolized, and that causes basically ketones. And so, you know, and that's what these types of diets are doing. So unless you're really making sure that you're clearing your ketones, yeah, that's just my thing. Not really a big fan. All right. On page 188, chemical acid-base control actions. So how are we going to control acids? One of the ways we're going to do it is a buffer, and a buffer is the first line of defense against changes in free hydrogen ion levels. What's a common buffer? Bicarb, like we've just been talking about. Bicarb is both an extracellular fluid and an intracellular fluid buffer, and also phosphate. There's also other ones. It says here protein buffers are the most common buffers. Those are things like albumin and globulins. And then an intracellular protein buffer is hemoglobin. So these buffers help to maintain this acid base. But it talks about it a little bit lower, and it says, okay, well, that's great. But what happens when these chemical buffers can't prevent changes in the blood pH? Well, what do we do next? Then we go to our second line, and that's the respiratory system. And that is the other thing that helps with this pH, our breathing, right? We start to breathe off CO2. And that's what it talks about there. Breathing rids the body of any excess CO2. And at the bottom of page 189, it talks about the respiratory regulation of acid-base balance is under the control of the central nervous system. So we've got receptors in the respiratory area of the brain, and they're sensitive to the amount of CO2 in the brain tissue. And that's what triggers the body to start breathing off CO2. So it just says it right there. Excess CO2 is blown off from the lungs, and the CO2 level in the extracellular fluid decreases. And that's what's going on there. And then, of course, the opposite can occur as well. If the central receptor senses too low CO2 levels, then we're going to decrease the rate and depth of breathing. We're going to do hypoventilation, all right? So just want you to be aware of those two things. On page 190, there's another line of defense, and it talks about the kidneys. So the kidneys are the third line of defense against wide changes in the pH. And these kidney changes are great, but they're not instant. It takes 24 to 48 hours for the kidneys to really start, for those responses in the kidneys to really start working. So just be aware of these kidney responses, what they do. It says it right here, there's several ones. Kidney movement of bicarb. The bicarb produces elsewhere in the body, and the kidney movement of bicarb produced in the kidneys. So basically, you're producing more bicarb. Formation of acids It says that's another piece that can be done as well. And then the formation of ammonium as well. So all of these pieces are helpful to make sure the pH is in the balance that it needs to be, whether it's that you need more bicarb or whether you need more acid. All right. Compensation. This is another big process. So when the pH isn't where it's supposed to be, the body compensates, right? The normal pH is what? What's our normal pH?
7.25 to 7.45.
Mm-hmm. Absolutely. And so we just talked about the compensatory factors that we can do. It talks about it here. The kidneys and lungs can compensate for acid-base imbalances, but they're not equal in their final responses. The respiratory system is a lot quicker and faster, and the kidney responses are slower, but have longer-term effects. So that's what's going on there. And it just talks about it again. All right. What did I want to say? It says here, when the lungs can fully compensate, the pH returns to normal. So when you're looking at these questions and you see a normal pH in the answer, you know that the body has fully compensated. If the pH is in the range, but not completely normal, then you know you've got some compensation going on, but not full compensation, all right? So again, it talks about it there with the kidneys. It says when adaptive actions are completely effective, acid-base problems are fully compensated, and the pH of the blood returns to normal, even though you may see differences in the bicarb and you may see differences in the CO2. With the pH being normal, you've compensated. Both the kidneys and the lungs have compensated to bring that pH back into normal range. Does that make sense? When you see it in these questions and when you see it in these problems, let's see. I have a question for you. So if I have a patient who has a pH of 7.50 and a PaCO2 of 30.
Respiratory acidosis?
Yes, it is. Yep. We're looking at respiratory acidosis. Yep. Right, so just wanted you to bear that in mind. All right, so let's talk about acidosis. It says here on page 191, acidosis is not a disease, it's a condition. It can be caused by metabolic or respiratory problems or both, okay? And at the bottom of 191, there's a nice little table, table 12.2, and it talks about common causes of acidosis. Can anybody give me some conditions that would cause, well, that's talking about, I'm sorry, well, it's talking about metabolic acidosis. So anybody see any of those conditions?
Isn't diabetes one?
Yeah. DKA, absolutely.
Does this have anything to do with like a pulmonary embolism?
I think I would see that more, not necessarily.
Okay.
But anything that's going to decrease the respiratory function, I would look at that more initially in respiratory acidosis, is what I would look at. That's how I would see it. So, you know, potentially those things could happen, but I think I would see it more first in respiratory acidosis. All right, so Metabolic acidosis, it talks about it there, right there, and it's the overproduction of hydrogen ions. It occurs with the breakdown of fatty acids, anaerobic glucose breakdown, lactic acidosis, and excessive intake of acids can occur. And so just like you were saying, Amber, DKA is an example of metabolic acidosis. And what happens there is you've got insufficient glucose available for fuel. So where's it going to get its fuel? It's going to get it from the fats, right? And it's this breakdown of fats that we see that basically causes this increase in ketones. And that's what's going on there. And lactic acid is going to build up in that case. All right. Respiratory acidosis. Give me some examples, it says here. So respiratory acidosis results when respiratory function is impaired. So to your point, Mimi, a PE would be a good example of that because the exchange of oxygen and carbon dioxide is reduced. So you're going to get CO2 retention. So PE is a good example of respiratory acidosis. Does that make sense?
Yes, ma'am.
Yep. It says here, unlike metabolic acidosis, respiratory acidosis results from only one cause, which is the retention of CO2. And then again, you're going to get those hydrogen ions increasing. And it says here, common causes, respiratory depression. It could be anesthetic agents, it could be opioids, it could be poisons, cerebral edema, inadequate chest expansion due to many issues, airway obstruction, or reduced alveoli capillary diffusion. So yeah, anything that's going to reduce the body being able to blow off CO2 and bring in oxygen is going to cause respiratory acidosis. So let's think about this for a minute. What type of things, based on chart 12.3, might we see with forms of acidosis?
Hypotension.
Yep.
And then
depressed
the
nervous
bradycardia.
Heart block.
That only makes sense because if you can't breathe, then that means you're going to have shallow breathing. So,
yeah.
Right.
It's called Kussmaul respiration. That's with where you'll get your DKA patient. You'll have an actual condition called Kussmaul's breathing, and that is where they're trying to breathe off the ketones, and you'll get that fruity breath. It's called. Okay, just to be aware of that. One thing I will mention to you as well, with worsening acidosis, you get hyperkalemia. What is hyperkalemia?
increased calcium.
Increase what?
potassium.
Yes. Yep. Increase potassium. I didn't hear you. All right. Let's see what else I want to bear in mind in this. If you look at the bottom, it talks about the fact when your acid-base imbalances are not compensated. That's going to mean that your pH is not in balance, right? Your body is trying to compensate. What are we always trying to do? We're always trying to maintain homeostasis. We're always trying to manage that balance. And if that's not occurring, that pH is not going to be in line. Even if the kidneys are doing what they're doing and the lungs are doing what they're doing, you're not going to have compensation going on there. So it talks a little bit about what you might see, and we already just discussed that. Acidosis in metabolic, you may see a certain type of breathing, like I just said, Kussmaul's respiration. If it's respiratory, breathing efforts are reduced. Respirations are shallow and rapid. You may see skin changes like vasodilation. You may see them eventually become cyanotic. Okay, cognitive awareness as well is going to decrease, all of those types of things. Arterial blood pH, That's the values that we're going to use, right? You can do an Allen's test. You're not going to do it. The respiratory therapist is going to do an Allen's test. They'll actually block off the radial artery, and they're going to draw the ABG from right here. I don't know if has anybody ever seen that done? The Allen's, okay. So that's how they actually draw the ABG, normally from the radial artery, by the way, just to let you know. All right. I think that you guys sort of get a little bit about respiratory acidosis and metabolic acidosis. But I do want you to be aware of this. On page 194, it talks about potassium. And this is relevant in light of everything that we were talking about earlier. It says the serum potassium level is often high in acidosis as the body attempts to maintain electroneutrality during buffering. So you're going to see the potassium level go up and up and up. And of course, that's another concern, isn't it? Because when we see that potassium go up, then we know we're going to have issues with our cardiac system, right? So that's another big concern that we've got going on. What else do I want to bring out about that? I think that's pretty much it. Metabolic acidosis, interventions for metabolic acidosis on page 195. What are we going to do for it? Well, hydration. We're going to do drugs. Obviously, if it's a DKA situation, then we're going to give insulin. We're going to correct the hyperglycemia. We may need, sometimes depending on what's going on with the potassium, they may give potassium, but of course you want to check your potassium first before you do something like that. They may give bicarb, that might be a situation as well. So they may have to give oxygen, of course, depending on what's going on with your patient. I'm pretty sure that they would give oxygen therapy. They may need, depending on what's going on with the patient, if they're decompensating, they may need to be ventilated. So it talks about all of those pieces there. Let's see. I think that's pretty much it, or what I want to talk about there. Alkalosis. So on the bottom of page 195, it talks about alkalosis. And of course, that's looking at bicarb, right? We have too much bicarb on board, so we have the opposite effect going on there. Again, alkalosis, it's not a disease, it's a symptom. It's looking at, oh my gosh, this patient is in alkalosis. Why are they in alkalosis? So then we're going to look at that on page 196. Can anybody give me some examples of the conditions that would cause alkalosis?
Blood transfusion.
Yeah.
Would that, does that just mean it'd be like the wrong blood, or would the blood not, I don't know. Like, what does that mean? Blood transfusion?
So here's the problem. You know, if you've got somebody with an obstruction and you put an NG tube down, and usually you put that NG tube down to decompress, or suppose it's somebody post-op surgery and they need an NG tube, and the suction is going, it's going to low wall suction, low intermittent wall suction. So they're pulling out gastric juices. Well, the thing is, we need those gastric juices. Those gastric juices is hydrochloric acid, all right? Acid, it's an acid that we're pulling out of there. So if we're pulling out the acid, what's going up? The bicarb. And so we're inadvertently creating an alkalosis. That's what's going on now. Does that make sense?
Yeah.
That's what's happening. Again, one of the other things, and Evelyn, I'm going to stand by what I said yesterday. If somebody's having a lot of diarrhea, but also a lot of vomiting, again, if they're having a lot of vomiting, then it's acid that's coming up. So potentially you can have a metabolic alkalosis because of all the vomiting that's going on, and we're getting rid of the acids. So it talks about it right here. Basically, it's acid deficits that are going on for one reason or another, and it could be many reasons. Respiratory alkalosis, slightly different reasons. It could be shock. It could be the ventilator. Basically, we're getting them to breathe off too much, and therefore that's sending them into an alkalosis as well. It says here in 196, the hallmark of respiratory alkalosis is an ABG result with an elevated pH coupled with a low carbon dioxide level. All right, so I just want you to be aware of that. It says usually the oxygen and the bicarb levels are normal, but the pH and the CO2 is going to be altered right there, and that's your respiratory alkalosis. So it talks about the symptoms of what you might see. I remember how I talked about Trousseau's sign and Chekhov's sign. You might see that with this type of patient, with the alkalosis type of patient. It says, and the reason is because their calcium levels are going to drop. That's what's going to go on. So often you see low calcium levels, you also see low potassium levels. So as a result of that with the alkalosis, because you've got this reduction in your electrolytes, then you may have those types of symptoms. You may see those things. You may see increased irritability, tetany. Like I explained to you, tetany is when you get that, I mean, you can get paralysis actually along with tetany. So I just want you to be aware of that. Muscle cramping, twitching, all of those types of things. The heart rate can go up. Tetany, it talks about it right here. Tetany, that's why we have our tetanus shots, right? As a result of tetany, continuous contractions, and actually you can get a sort of worsening condition where they can go into paralysis, just to let you know. Cardiovascular changes, like we talked about, respiratory changes, of course, you can get respiratory alkalosis. And it's not usually, it says, although the volume of air inhaled and exhaled with each breath is nearly normal, the total volume of air inhaled and exhaled is not necessarily the same, and the respiratory rate is increased. So that's what it's talking about there. Your arterial blood pH is going to be higher, right, than 7.45, and that's going to be your alkalosis. And that is basically it. Wow, that's really not bad at all. So why don't we do a couple of ABG questions? Would that be okay with you guys?
Yeah.
Yeah. Okay. Because I think we really talked pretty much about IV infusion a lot yesterday. Would you say we did? Pretty much chapter 13. I think we pretty much covered it. It doesn't mean that I don't want you to read it, but really we covered chapter 13. So I would like to, sorry, Kane, just scared my cat. Why don't we do this? Let me find freehand. Where were you? What was it called? Freehand. Is it posting? Can you guys see it or not?
No.
I see nothing.
Okay. Give me a minute. Okay, can you see it now? Can you see it?
Yeah.
Okay, great. All right, good. All right, well, as I say, there's two, as you, I'm sure, as you did originally in your funds class, there's two ways of looking at how you want to determine an ABG, right? Some people prefer the Rome method, and like I said to you, that means respiratory opposite metabolic equal. So do me a favor and pull out, I'm looking for a chart for you guys, a quick sort of down and dirty chart. I know Evelyn has one, but you may not, where it shows your normal pH, 7.35 to 7.45, your normal CO2, which is 35 to 45, and your normal bicarb, which is usually 22 to 26, somewhere in that region. And would you like to do a couple of ABG questions? Would that be a good idea, just to, as a refresher, to be helpful?
Oh, no refresher, I need that.
Okay, all right. So you can use whatever method you prefer. I'm more of a tic-tac-toe person, so if you don't mind, I'm going to use that format. Is that okay with you guys?
Please.
Yeah, in my other class last time, I had a couple of people that were that they liked Rome. I actually like tic-tac-toe. So with that, I'm going to draw my tic-tac-toe. Have you done this before? I'm sure you guys have. Yeah.
I don't remember it, but I've done it.
Okay. So why don't we do this? So basically what you're doing is, this is your, and I might need Amber's fabulousness for this. This is your acid. This is your normal. And this is going to be what I call base or alkaline, all right? So with that in mind, why don't I do this? I am going to type a question, and you guys, based on this, and I'm going to help you with it. We're going to plug in where the pH should go, where the PCO2 should go, and where the bicarb should go. All right. So let's look at this one. All right. So if the pH is 7.23 and we have a PCO2 of 50 and we have a bicarb of 30. All right. So first of all, where do you think that the pH should go? Is it acidic? Is it normal? Or is it alkaline?
Acidic.
All right, so where would you put it?
And
And just the pH.
Oh, do you want me to put it there?
Yeah.
Wow.
All right, wait, I'm a little confused. Hold on. So the pH is
2.3, so it's
There
lower.
you go. Yeah.
acid does.
So this is why you need to know your values. Okay. So we know that that pH is acidic. Okay.
Right.
So even if we don't know anything else, we know that. So we know right off the bat that we've got something acidic going on. Okay. So let's look at our PCO2. Is
That's
that
high.
normal? It's high. Okay. So what does that mean? Is it acidic?
Respiratory.
Alkalosis.
You think the PCO2 is alkalosis? Look at your, do you have your
It's
chart?
acidosis. Right?
What is it? Respiratory acidosis.
The
So do you have,
Respiratory acidosis.
okay, so where would your PCO, before we go any further, if it's acid, where, put that, just put PCO2 under the acid for me. Okay, so look at that. We have a tic-tac-toe. Bam, right here. However, I haven't finished yet. The bicarb is 30. So is that normal?
It's high.
It's high. What does that mean?
It's compensating.
No, right, but what does that mean? Is it acidic or is it alkaline?
Alkaline.
Okay. Put it in the base section for me. All right. Yes. So what do we have based on this?
Respiratory acidosis with compensation.
With compensation. But is it fully compensated or not?
Partially.
Partially. You
Why?
got 2 acid and 1.
Why is it only partially compensated?
Because you got 2 acid and then 1 alkaline.
But what am I asking you? Remember what I said when we read the book. If the pH is what? Normal.
Low.
Normal. If the pH is normal, you have full compensation. If you don't, then you've got partial compensation. So the pH is not in this normal section here. It is on this side. You're right, but I just want you to get in your brains. Is that helpful?
No.
No.
I
Shall we
was
do?
just confused. I don't know what. Okay.
Do you want to do another one?
Yeah.
Yes.
Yeah. All right. Let's erase this one. And why am I not deleting it? Where's the delete thing? Ah, shoot. All right. Let's do another one. Sorry, that's not very good. All right. So this is acid. Is this the way you've done it before?
Yes.
Yeah.
So is it confusing or is it helpful?
It's confusing to me, but that doesn't mean that it's not. I mean, that doesn't mean that it's not helpful for somebody
Yeah.
else. So I just prefer
Why
you
is
do
it
more.
confusing to you?
Very much so.
It's a lot to learn. It takes a lot of time to get this. This is why we have respiratory therapists, right? And that's all they do. Thank God for them. That's what I say. So here's another one. We have a pH of 7.22. We have a PaO2 of 49, and we have a bicarb of 24. Huh, what are we going to do with that?
We
Same
got
thing you already
what?
did. The pH is low, so that's acid. The CO2 is low.
Whoa, one thing at a time. So could somebody please put that pH in there?
I don't see it. Why don't I see it? It's over here.
She didn't put it up there.
Yeah, I don't see it.
She didn't write it yet, Evelyn.
Oh, sorry.
I'm asking you to put it in there. One of you, put your pH in there. Put the pH where it's supposed to be. If it's acid, where would you put it?
I don't even see a chart. Is that what we're talking about? Is the chart
Yeah.
up there?
You don't
Okay.
see this? You're not seeing it? Okay, let me see. Huh, interesting.
Is that what I'm doing?
Okay, so you don't see it. Is that the problem?
Yeah.
Oh, all right. All right, give me a second. Do you see it now?
No.
No.
See you.
See me. That's not helpful.
I thought it was because she didn't put it up there yet, Evelyn. That's my bad.
No, I did, but it didn't. All right, so let me start again. Sorry, guys. thought you were seeing what I was seeing. Weren't. So we know this is acid. We know this is normal. Do I need to write it all out, or have you got that, right?
Yeah.
So let me write the question out. So the pH is 7.22. The PaCO2 is 49. Are you seeing this?
Yes.
Mhm.
CO3, okay, is 24. So what do we have?
The pH is an acid.
So could somebody
The
put that?
pH is very low.
Just one thing at a time. So we've got an acidic pH. What do
Yes.
we have with the CO2?
High.
The CO2 is kind of, yeah. High.
What does that mean? Is it acidic or base?
It's acidic.
It's acidic, so put it in the acidic section. Somebody? Okay. So we know that we have some form of
And it's normal.
well, why I'm asking this, you know we have a respiratory issue, right?
You're echoing.
I know. That's true. What's your bicarb?
It's normal.
So put it in the normal section. So we have an acidosis of some form. Is it respiratory or metabolic?
Metabolic. No. I don't know.
Okay. Does anybody else know? It's respiratory. You have because the PCO2, the breathing of your pH, your respiratory. Okay. So you have a respiratory issue. You remember with respiratory in your book it said with the opposite. So if your pH is low and your PCO2 is high, you've got a respiratory issue going on, which you do. You have a respiratory issue going on. Your bicarb is completely normal. So it's what's happening here is your kidneys haven't kicked in yet to try and help with the situation at all. They're kicking back. They haven't been even alerted that there is a problem and they need to start compensating. If they were compensating, it would be here. So you have a respiratory acidosis that is not compensated. It's not trying to help the situation at all. Does that make sense? A little bit?
Very little.
You want to do another one?
It did make sense to me. Just okay. So so the HCO3 is normal, correct?
Mm-hmm.
Isn't that what determines if it's compensated or not? Or is it just the pH that?
The pH, and that's why I was bringing that out.
Okay.
If pH is normal, you've got full compensation. If the pH is not normal, then you may have partial compensation if it's within the range. But if your bicarb is kicking back and not doing anything, meaning your kidneys are, remember we said the PCO2 relates to the breathing and your bicarb relates to your kidneys. There's a lot of information that I threw at you.
Yeah. No. Okay. Okay. So my pH is low. It's 7.22.
Mm-hmm.
My PCO2 is high, and my HCO3 is in normal range.
Yeah.
And that doesn't give you partial compensation?
There's no compensation going on there
How come? Because you said like in the other one,
because the pH isn't normal. The pH is not normal, and the bicarb is not helping out.
oh, that's right. Okay, I got it. The bicarb has to be high to help.
That you would see your bicarb here.
High.
Your kidneys would be, your lungs would be saying, hey guys, I need some help here. And your kidneys would be saying, I've got your back. Let me jump into action and help you out. All right. But your kidneys are saying, oh,
Okay.
I'm still asleep and I haven't even joined the party yet.
Okay.
See what I'm saying? They would be here. And then your pH would hopefully shift more into the normal.
Okay. All right, do another one.
All right. Fun, right? You know, I'm trying to find my erase thing on here. For some reason, there should be an erase thing, and I don't know why. I'm normally able to erase. I don't know why I can't. Huh. Can somebody erase this for me, please? If you have it.
No, you can go to your three
Yeah.
dots. And then there you go. Export the image.
Oh, good. It keeps, yeah, there we go. All right, let's do a different one. Let's do a metabolic one. Give me a minute. I'm trying to find one for you.
You just gave us the answer.
Let's see. You can see the answers. It's not about the answers to me. It's about helping you understand process, right?
Yes, ma'am.
That's the key. Once you get that, it clicks in, then you'll know your answers. All right, let's just do 2 more and we'll call it a day. Let's do this one. So this is acid. This is normal. Base. All right. This one is, we're going to do an alkalosis one, just so you can get the swing of it. So I'm going to tell you what it is. We already talked about it. So the pH is 7.51. CO2 is 47. Carb is 32. Oops, I'm sorry. 32. So what have we got here? Where's that pH? High, right? pH is high. Oh, what is Jesus? So if the pH is high, what does that mean? Yeah, thank you. We've got some
pH is too high.
Yeah, so we've got alkalosis going on. What about that CO2?
It's too high.
Did you write something?
Can you can't see this?
Oh, haha, I see.
Okay.
Shut up, Amber.
What's the PCO2?
I'm sorry.
So what is that? Is that acidosis or alkalosis?
PCO2 is 47.
47?
Greater. It's acidosis.
Okay.
Oh, which one? The CO2 is acidosis.
Yeah.
Yeah.
So put that where it needs to be. Okay. What about the bicarb?
It's high.
It's too, yeah, it's high.
Right, it's high.
So
It's
alkalosis.
high. So what does that mean?
You got something alkalosis. You are, I
Right,
want
so
to say,
hang on.
metabolic.
One thing. you've got your bicarb that's high. Where's it going to go? Is it going to go in acid or base?
What are you talking about? The HCO3?
Correct. Where
It's alpha.
There's gonna be base.
put it there. All right. Where's your tic-tac-toe?
It's alkalosis.
Yes, it is alkalosis. What's
And I think that it's
yeah, you're right.
Is it?
it's
What is
metallic.
it? Metabolic?
It's metabolic. Yeah, it's
Metabolic.
metabolic because it's all on this side, right? It's a metabolic alkalosis that is going on. That's exactly right. You got it right. And if you wanted to check yourself with the Rome thing, if you looked at Rome, like they said, respiratory would be opposite, but the metabolic would be equal. And in this case, it is. The bicarb and the pH are equal, meaning they're on the same side. So they're both up, right?
Okay, I have a question, and maybe it's because we keep switching terminology from which one is bicarb?
Bicarb is HCO3. That's bicarb.
Okay,
Yeah. In your
let me
book.
write that down because
Yeah.
I think that's what's.
That's confusing you.
Yeah, we're confused. We're changing the terminology. So I'm like, what? But I need to know it all, so it's cool. And then PaCO2 is just respiratory. It's no other name for that, right?
Correct.
Okay.
Well, it's carbon dioxide. That's what this is. CO2. PaCO2 is carbon dioxide.
Okay, gotcha.
All right. So the other question I have is, are we compensated or not?
No,
Why?
because everything is on the alkaline side.
Yeah, the pH isn't in the normal range, right? But what you have is you've got alkalosis, and here we have your pH is acidic. I'm sorry, your PCO2 is high. Your bicarb, ignore me. Your CO2 is high, carbon dioxide.
So the only way that we can be compensated is what?
Well, it's partial compensation right now because as you can see, you've got nothing in the middle that's normal. Nothing is normal. But what's happening is, I don't know if this person's vomiting a lot or what's going on, but your lungs are trying to help out and compensate for what's going on as well. So you've got both areas working, and that's where the compensation comes in. But you can't call it completely compensated because your pH is not normal yet. Not normal. If it was here, then we would have completely compensated.
So
The
pH is normal, and then you have one in the acid side and one in the alkaline side. Then it's full compensation.
You got it.
Okay, I gotta write that down.
Okay, one more.
All right. Let's see. Give me a minute. For you. All right, let's. Oh. Now, I'm just saying, your I would suggest in your NCLEX book, that chapter 9 that has the acid-base balance questions, that all of you do every single one of those. All right? I really think it would be a good idea to do chapter 9 in your NCLEX book, in the Silvestri book.
Mhm.
I think that would be wise. Let's see. I'm going to do another metabolic one. Oh, I'm sorry, I didn't put the A here. That's normal. How do I get over here? Why is it not letting me do it? All right, guys. I don't know why it won't let me do it. I have to click off it each time. You have to click off it each time, don't you, Amber? Is that
Yeah.
right? It's a pain, isn't it?
It's a pain.
I know. All right, well, you guys know that this right here is alkalosis. All right. You know that? You're with me on all that? All right, so let's do your numbers. So the pH is going to be 7.37. The PA, and sometimes you'll see it as PaCO2, sometimes you'll just see it as PCO2, sometimes you'll just see it as CO2. But anyway, okay, is going to be 33. And then the bicarb, this is bicarb, 17. Oops, can you see that, guys?
Yeah.
You can? All right. So based on that, where would you put your pH?
Normal.
Okay, so could somebody put that in there? All right. Where would you put your carbon dioxide, the PaCO2? What is it? Is it acidic? Is it alkaline? Is it... All right, put it in there.
Oh, no.
Right.
There we
You're
go.
having no problem. All right.
Good.
And then what about that bicarb? Is that normal? What is it?
It's
Acid.
acidosis.
It's acid. Put that in there. Put that in there. Interesting. So this is a sort of slightly interesting one. So we have an acidosis. We have an acidosis that's going on. The pH, what's the normal pH?
7.35 to 7.45.
Okay. So because the pH is very, very slightly on the acidic side, we have an acidosis. But because it's in the normal range, pretty much, it's compensating. But is it metabolic or is it respiratory?
Metabolic.
It's metabolic. Yeah. Because we have the metabolic piece going on here. And I'm sorry, we have the metabolic here, and your lungs are compensating. So yeah, it's not easy. ABGs are not easy at all.
And that one will be full compensation?
Yes, this would be full compensation because the pH is in the middle. All right. Trying to think of how else I can help you. Oh, I know. On your chapter 9, there's a table It's page 103. I don't know if you have the same book as this one, but page 103 or table 9-4. And it just gives, again, a little cheat sheet of what you're looking at to help you understand when something has respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. And it will say what's increased, what's decreased, pretty similar to probably what you have, Evelyn, on your cheat sheet. But that might be helpful for some people as well. And it's not easy. A lot of it is memorization, quite frankly. You know, just doing it again and again and again and again and again. But I would definitely say to look at this book, look at this chapter 9, and really understand that chapter. Just before we go, what did I want to look at with you? Chapter 12 and 13. Oh, yeah. All right, so I'm going to get rid of this right now. Let me clear this. Export. Where would it go away? Downloading it. Lord. All right, let me get rid of this a second. Well, I can. How can I get rid of it? Okay. Sorry, guys. I don't really. Can you see all that? Because I'm trying to get rid of it. It won't go away.
I don't see it.
You don't see anything?
Mm-mm.
Okay. All right. Well, I don't know why I can't see you all. For some reason. Okay. Well, anyway. A couple of other things I just want to talk about. Chapter 12 in your NCLEX book. I want to do a couple of practice questions with you, and you can blame Evelyn for this. I don't know why I can't see you, and I can't seem to get rid of the freehand thing. That is really irritating. There we go. Hallelujah. All right. So, question for you. Stop sharing. Question. This is looking at TPN, and I don't really know that I taught much about TPN. Do you know what TPN is, first of all? Some people are saying yes, some people are saying no. So chapter 12 in your NCLEX book, I suggest you learn a little bit about TPN and lipids. And basically what TPN is total parental nutrition. And it's a form of nutrition when patients can't tolerate anything orally, or they can't actually, their gut isn't working for one reason or another. So they have to have their nutrition via an IV. So this is going to incorporate all of their electrolytes, all of their amino acids, all of those types of things, and their fats as well. And normally what you're going to see is a big yellow bag with all of those types of needs based on their calories and based on their height and weight and BMI and all of those things. You're going to see glucose in there. It's a very, very high concentration of glucose. I want to say the concentration of glucose, and I think we talk about this a bit later in the class. But anyway, it's a very highly concentrated glucose. You normally do not give this via a peripheral line. It normally goes via, and Alicia knows what I'm talking about, it normally goes via a central line. Now, there is a form of TPN, total parental nutrition, that can go via the peripheral line, but it's a lower concentration of dextrose. I want to say only up to 10, maybe 10% dextrose. You can't go higher than that. And I'm looking in your parental nutrition chapter to see if it says it for me. And it might be that I'm just not looking in the right place, but it does have it in this other book. And I will get that rate for you because you may need to know that, the amount of dextrose related to TPN versus PPN. But what I want to bring out, and I think less than 10% can go via the peripheral line. Anything 10% more has to go via the central line. But anyway, also what you're going to find along with it is the fats as well, and that's normally in a glass container, but I've noticed it tends to be in a PVC bag now as well, and it's normally a white white milky fluid that you will see, and that's the fats that go along with the TPN. And normally the TPN is like a 24-hour infusion, and you can imagine, because it's so high in dextrose, that it because it's got a lot of sugar in it, what could that attract? Any idea?
No.
Infection. All right. So with it being highly concentrated with sugar, it's a high risk for infection. That whole thing gets changed out every 24 hours. All right. Every 24 hours, that bag gets changed out, whether it's still got stuff in it or not. Okay. That's something that you will notice. It's a policy that needs to be. So every 24 hours, that bag is going to get changed. And the fats normally are wire connected into the bag along with the TPN. So I want you to be aware of this. And one of the questions that may pop up, and I've seen it a couple of times, is the fact that these fat emulsions are often prepared with soybean, safflower, or egg yolk. And so what type of allergy do you have to make sure that your patient doesn't have for them in order to be able to have the TPN, or rather the fats?
Lactose.
Egg.
Oh.
So any patient with an egg allergy, you're not going to give this type of fat emulsion to, because a lot of the time it has egg yolk in it, all right, or certainly some form of egg. So this is why I want you to be aware of it. And I would definitely read this chapter on TPN, because I have seen some elements now and again on your HESI, that type of thing, with this type of questions. So based on that, let me see. What nursing action is essential prior to initiating a new prescription of fat emulsion? 1, determine that the client doesn't have diabetes. Determine whether the client has an egg allergy. Add regular insulin to the fat emulsion using aseptic technique, or contact the healthcare provider to have a central line inserted for the fat emulsion. What do you think?
The egg allergy.
The egg allergy, yeah, the egg allergy. And just to let you know, often they will put insulin in the TPN. They will put insulin in the TPN. Now, I think we do talk about TPN in your med-surg book in another chapter, but I do want you to be aware of these things. Let's see. Based on what I told you about, you need to change this bag every 24 hours because of infection. Here's another question. A client has been discharged to home on parental nutrition. With each visit, the home care nurse should assess which parameter most closely in monitoring this therapy. Pulse and weight, temperature and weight, pulse and blood pressure, or temperature and blood pressure.
And blood pressure.
Did you say temperature and blood pressure, Rhonda?
That was me.
No, that was Miss Fitz.
Okay. Okay.
I'm wrong though. I got half that question.
Okay. Let me repeat it. Do you need the whole question or the answers? Let me repeat it. A client has been discharged home on TPN. With each visit, the nurse is going to evaluate what parameter most closely. Pulse and weight, temperature and weight, pulse and blood pressure, or temperature and blood pressure.
It's the second one, right?
Correct.
To wait.
Temperature and weight.
Because the whole goal of giving the TPN is for them to build weight, you know, better nutrition. So
Yeah.
they're malnutrition at this point.
Correct. But we want to make sure they don't get a fever because, like I just said, basically TPN is wonderful, but it is a breeding ground for sepsis. Okay, so you have to be really careful with TPN because it's basically all sugar. So that's what you need to be aware of with that patient. All right, so I would suggest that you look carefully at chapter 12. Now, chapter 13 is all about IV therapy, and it isn't actually in your reading, but you may want to look at it anyway because it does sort of go over some of the things we talked about. One of the things that I thought was interesting, and then I'll let you go, it does say don't write on the plastic bag, which we sort of used to do. We have, of course, the little labels that you can stick on there and things like that, but sometimes you might see somebody writing with a marker on the plastic bag. You don't want to do that because remember how I talked about leaching, how plasticides can leach? Well, of course, the concern is that, you know, the marker pen, that those toxins could leach in as well. So it's something to just be aware of, that those could be absorbed through the plastic, okay? And it does point that out. I know that's not part of your actual reading, but at some point it's going to be, so it's useful to know that. All right, I think you've had a pretty full day, right? Are your brains full?
It hurt.
Your brain hurt?
Yes.
Yeah.
Did you learn anything?
A lot.
Yeah. ABG,
Good.
yeah.
Well, that's what it's about, right? I will look at the quiz for you guys and get that evaluated. Remember your remediations, remember your homework. Oh, and as I say, it's sort of exciting that we're going to be able to go to lab, all right? And that will
Kayla,
be,
mute yourself.
just bear these dates in mind and I will get them for you. But I think it's going to be the 19th of August, which is that Wednesday class. So from 9 till 12, we're probably going to be in the lab at Concord. And then again, September the 2nd, from 9 till 12 in the lab. All right. So you'll get the chance to practice on dummies and things like that. And do you like that idea?
Yeah.
Yeah?
I'm all about that idea.
Good. Good. All right, so just bear those dates in mind, the 19th and the 2nd, instead of sim online, we will be at Concord. But I'll not make it 8 a.m. We'll get there for 9. From 9.
So they're trying to slowly get us back to the campus.
Well, I think we did do a little bit of this last term, but we have to do it in very small groups, and you're a small enough group that we can do that. So, I mean, really, we're a small enough group that we could probably meet on campus, but they're still doing. So let's at least do lab time there, and that'll be a bit of fun. Get you doing an NG tube on a dummy and things like that. Some Foleys and anything else you want to do. Okay, well, if there's an EKG machine, we'll hook you all up to EKGs, and why not? Okay. All right. Well, I enjoyed this week with you guys. Look forward to seeing you on Tuesday for clinical, 12-hour day, and we will go for them. Always open to suggestions, and we'll have a lot of fun. All right. I know we've got.
Can you tell us our times again? Do we have a date today?
It's on the calendar.
It is. Oh, look. Yes, ma'am. Thank you.
Look on the calendar.
Miss Fletcher, can I go back on the calendar and reschedule it?
I think you can. You mean for next week? Is that what you're saying?
Yes, ma'am.
Yeah. You can go on the calendar and just reschedule. No problem. Okay. Let me know if it doesn't. If you're not able to do it, just let me know when you want to reschedule it. But I have Mimi, and I want to say there were 3 of you today. I can't remember off the top of my head.
Yeah, we're meeting at 1:30. Sorry.
There you go. Amber, and then Mimi, and then Rhonda next week. Just have a look at the calendars on Outlook. So just pop yourself on the calendar. All right. Take care, guys. I'm glad you've learned a lot. I'm glad your brain's hurt. Yay, I've done a good job. All right. Take care.
Bye.
Bye, y'all.
Bye-bye.